Hello, thank you for inviting me to speak on considering delay in cholecystectomy in the third trimester of pregnancy. I have no relevant disclosures. Cholecystectomy is the second most common non-obstetric abdominal emergency in pregnancy. It affects as many as 1 in 10,000 to 1 in 1,600 pregnancies and is likely related to gallbladder hypomotility and increased estrogen in pregnancy. Smaller retrospective studies of 56 to 58 patients suggest that deferring cholecystectomy during pregnancy may result in higher rates of recurrence, ED visits, and repeat hospitalizations. As of 2017, SAGE's guidelines recommend laparoscopic cholecystectomy for symptomatic gallbladder disease in any trimester of pregnancy. Recently, these recommendations were called into question after a large retrospective study using Californian population-based data concluded that third trimester cholecystectomies are associated with increased length of stay, preterm delivery, and 30-day non-pregnancy, non-delivery readmissions. In response to this large-scale paper, we developed a retrospective population-based study using data from SPARCS, a New York statewide all-payer database, to assess how timing of peripartum cholecystectomy affects the risk of surgical and obstetric adverse events. We scanned the SPARCS database between 2005 and 2014 and found over 1.4 million singleton deliveries. Of these, we included only patients who underwent cholecystectomy within 10 months before and 3 months after delivery. We included patients with ICD-9 codes for benign biliary disease, such as biliary colic, acute cholecystitis, choledocholithiasis, and gallstone pancreatitis. We excluded patients below 18 years of age, patients with twins or triplets, patients who underwent abdominal surgery other than cholecystectomy, and patients with ICD-9 codes for malignancy of surrounding structures. We collected multiple demographic variables, and we collected multiple data points on the surgery itself. But for the sake of time, we will focus on timing of cholecystectomy. For primary outcomes, we collected 4 surgical and 4 obstetric data points, including bile duct injury, 30-day readmission unrelated to pregnancy and delivery, length of stay, any complications, preterm delivery, and fetal demise. For univariable analysis, we used chi-squared test with Monte Carlo simulation to approximate p-value for categorical variables, and Wilcoxon rank sum test for continuous variables. For multivariable analysis, we used logistic regression for categorical variables and generalized linear regression model for continuous variables. On intertrimester analysis, we were alerted to the worsened outcomes seen in third trimester patients. They had nearly double the rates of preterm delivery and longer length of stay when compared to first and second trimester patients. Third trimester patients also seem to have a disproportionately higher number of open versus laparoscopic cholecystectomies. When comparing the third trimester group to the postpartum group, the third trimester group was slightly older, with much higher rate of open cholecystectomy and greater incidence of hospitalization. Third trimester group was also at greater risk for gallstone pancreatitis. On multivariable analysis, third trimester patients experienced up to 1.4 times longer length of stay and were 2.5 times more likely than postpartum patients to encounter preterm delivery. Adjusted analysis for the remaining surgical outcomes were not related to timing of cholecystectomy. These outcomes were more likely related to surgical approach and baseline patient characteristics such as obesity, which is another risk factor for cholelithiasis. There was a borderline association between third trimester cholecystectomy and fetal demise, but the very low incidence precluded multivariable analysis. From these results, we drew 3 discussion points. First, we found that third trimester cholecystectomy was associated with increased preterm delivery and prolonged length of stay. We were unable to replicate increased readmissions or complications. We were unable to identify differences in bile duct injury or fetal demise. Second, Although there was an association, we cannot guarantee causation between length of stay, preterm delivery, and third trimester cholecystectomy. Increased length of stay in the absence of increased complications and 30-day readmissions suggest non-medical or non-surgical reasons for discharge delay, such as increased monitoring required to clear a pregnant patient for discharge. Finally, we have no reliable measurement for disease severity, which may by itself increase risk of preterm delivery by methods such as intra-abdominal inflammation. Without accounting for disease severity, we cannot be sure that third trimester cholecystectomy causes preterm delivery. Third, even if delayed cholecystectomy leads to improved results in terms of preterm delivery and length of stay, there is no completely reliable method for non-operative management of biliary disease at this time. Attempts to delay cholecystectomy in pregnancy is time-consuming and costly, as these patients are at risk of rehospitalization, ED visits, C-sections, and early induction. Adjuncts to non-operative management, such as ERCP with sphincterotomy, may improve successful delay, but this adjunct is also an imperfect solution with possible radiation-related risks to the mother and fetus. Limitations of this study include unknown symptom onset and disease severity. We did not account for crossover from patients who were converted from laparoscopic to open cholecystectomy. We estimated gestational age retrospectively from delivery date and did not have accurate trimester measurements. And we were unable to determine which patients truly did or did not defer cholecystectomy during pregnancy. Finally, with differences in population composition across states, generalizability of these results beyond New York State may be limited. In conclusion, third trimester cholecystectomy may carry an increased risk of preterm delivery and extended length of stay. Surgical outcomes do not seem to worsen in third trimester cholecystectomy. Unmeasured confounders such as disease severity and duration likely exist. And because methods for delaying cholecystectomy are not yet fully reliable, strongly recommending against antepartum cholecystectomy may limit otherwise viable options. Until large-scale data looking at delayed cholecystectomy is available, patients may benefit from case-by-case evaluation for third trimester cholecystectomy. I would like to thank the prior lab at Stony Brook, as well as the biostatistical core at Stony Brook, for their research guidance and continued mentorship. Thank you very much.